Okay, so today is the first time we were doing the EuroCuff test in Alaska. This test is designed to tell us the difference if there's an obstruction in the prostate versus the bladder is weak. And patients that have a slow flow can either have a weak bladder or a strong bladder but with an obstructing prostate.
You're using the Urocuff to interrupt the flow of the patient. At the point of interruption, this is equal to bladder pressure. So the amount of pressure required to stop the patient's flow is equal to bladder pressure. So a quick example, initial patient essentially will come in and he's going to score, just beginning to have symptoms. He may have an elevated pressure, but still what we would consider a normal flow and a normal pressure. Once the obstruction increases, this will move the bladder to compensate into having to provide higher pressure to maintain the same flow. So now he's a high pressure, high flow patient. At this point, the bladder cannot compensate anymore. So if the obstruction continues to grow, he essentially is going to be moving into lower and lower in flow until the bladder is essentially going to begin to decompensate and would fall into a low flow, low pressure category. The beauty with this is that not only are you able to use it as a diagnostic for actively managing BPH, but you can also identify if you're dealing with a patient that has overactive bladder. So if you have a patient that comes in, depending on their symptoms, this may be a younger patient, he's complaining about being up, several times a night. You go ahead and run this test and he's showing normal flow, normal pressure. You have 4 quadrants that will diagnose the patient on the nomogram. The first quadrant is normal flow, normal pressure. So for that patient who has severe symptoms and has a normal pressure, normal flow, this is most likely pointing to overactive bladder. Okay? So for most other patients, you're typically dealing with BPH. So it's a matter of what stage are they in with dealing with their BPH. So you may start off with a elevated bladder pressure, however, still here considered to be normal. You would start a medication protocol, and then you continue to manage that patient. Maybe you have a 1-month follow-up, to see how he's doing on meds, to see if your bladder pressure has changed as a result of BPH medications. So you gauge that with a follow-up. Maybe it's a 6-month follow-up, and what you're finding is the patient has now moved into a higher bladder pressure, relatively the same flow, symptoms are relatively the same, but now his bladder pressure has increased into, compensating to performing at maximum pressure.
So in this quadrant, the bladder pressure has gone up to compensate for the obstruction, and that's why the flow is still good. Like, let's say this is a flow of 15 or 14 and 15, which is considered good flow. Mm-hmm. But if the patient is up here, that means that the bladder is generating too much pressure to generate this flow. And this could be dangerous because in the long term, bladder deterioration can happen with high bladder pressure. And then what happens eventually with the increased obstruction, that same pressure, this is the pressure axis right here. That same pressure is no longer able to generate the same flow because now the obstruction is preventing that flow from flowing through. So now we get high pressure and low flow. So that's when we start having a high post-void residual. The bladder still has some leftover urine in it, despite having generated a lot of pressure. And this is a very dangerous area because you have a lot of pressure as well as low flow.
Right, and very quickly, this is kind of the typical life cycle of the bladder dealing with BPH. You start with a normal flow, normal pressure. You're moving into high pressure, high flow, then high pressure, low flow, and then eventually going to drop into low pressure, low flow. We know statistically with studies that if we can intervene with this patient with a deobstructive procedure prior to him dropping into this low flow, low pressure category, you have a 92% chance of success with symptom relief with this patient versus around a 22% chance if he's to drop below the line into a low pressure, low flow. So this is our opportunity to provide intervention and prevent prevent a procedure that still is going to need to be done, and yet you have a very low percentage chance of relief from symptoms.